I'm Ann O'Day from the University of Kansas Cancer Center. I'm a breast oncologist here, and I'm so honored today to have a very esteemed board of presenters for you all. I'm going to ask that they each just introduce themselves. I think maybe we'll start off with Dr. King.
My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Institute. And it's a pleasure to be here with you and with all of my colleagues today to discuss these cases.
I'm Chirag Shah. I'm the Director of Breast Radiation Oncology and Director of Clinical Research at the Cleveland Clinic. It's a pleasure to be with all of you this afternoon.
Mark Hegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute in Palo Alto, California. Thanks for inviting me to participate in today's tumor board.
Hi, I'm Maxine Jockelson, and I am the Director of Imaging at the Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am both a breast imager and a PET reader. And I'm really thrilled to be back doing this conference with you.
Our next patient is a 74-year-old woman that has, importantly, a history of rheumatoid arthritis on methotrexate, and also a left breast invasive ductal carcinoma, stage 2A. That is a T2N0M0 triple negative grade 3 cancer, who had a partial mastectomy with sentinel lymph node biopsy, demonstrating no lymph node involvement and negative margins. Now, with a delay in getting to her adjuvant chemotherapy and radiation, she's reevaluated 6 months after surgery with CT imaging that demonstrates a prominent left axillary lymph node, but no other suspicious sites of disease. So the question that is being posed is sort of the best management options for her at this time. Should she undergo axillary lymph node dissection or less invasive biopsy? Should she proceed straight to her adjuvant chemotherapy? And is the benefit of adjuvant radiation with such a delay worth the risk of increased toxicity with her active rheumatoid arthritis? So her initial presentation was with screening mammography, a 2.3 centimeter screen detected mass, 7 centimeters from the nipple. She had a preoperative MRI, which demonstrated a 4.3 by 2.6 by 3 centimeter necrotic left breast mass at the 9 o'clock position. She had a staging CT chest, abdomen, pelvis with no signs of metastatic disease and 1 left axillary lymph node. And we're going to look at those with Dr. Jockelson in just a moment. She had the biopsy and ultimately resection with a wire localized left partial mastectomy that demonstrated a 3 centimeter invasive ductal carcinoma. There was a 0.2 centimeter posterior margin, all the other margins more than a centimeter. This was a grade 3 tumor with 0-1 sentinel lymph nodes involved. And the final pathology demonstrating an invasive ductal carcinoma with marked necrosis, triple negative, with a Ki-67 of 40%. The PD-L1 status is unknown. And so we'll ask Dr. Jockelson for us to just kind of point out for us the pertinent findings on the CT scan of the chest.
Okay, so we have a single view, and she has a goiter. Not relevant probably. And then the arrow is pointing to a single node, which is measured as 0.9 cm. So the actual size of the axillary node is not relevant. It's really the cortical thickening that is the important thing that you look for, and it's very hard to see that on a CT scan alone. So the first thing nowadays, I'd ask her if she'd had a COVID vaccine recently in her left arm. But if that hadn't been the case, I would ultrasound it, because at 9 millimeters, if she has normal cortex and her fatty hilum is there and she's a patient with rheumatoid arthritis, she may very well have an inflammatory process. So this may not be malignant at all. If on ultrasound it does look slightly abnormal, I would do a fine needle aspiration before I would make any other decisions.
Okay, perfect. How about this coronal image? Does that change your thoughts at all?
No, you can see the goiter nicely, some calcifications, but no, I find it's pretty hard on cross-sectional imaging to be as confident as you are in ultrasound. And if you look at the literature, comparing all the various modalities we have, I think ultrasound is the best suited for getting a look at the cortex and deciding whether or not you're going to get tissue.
Okay, perfect. Thank you so much. So Dr. King, if you might comment for us, after her initial surgery, which was of course done with curative intent, and now with these findings, kind of how you would approach this patient. I think Dr. Jockelson is weighed in for ultrasound and possible biopsy, but if you want to comment from a surgical perspective.
Certainly. So at her presentation, she was a candidate for the Z11 approach. So she presented with a clinical T2N0 breast cancer. She underwent a lumpectomy with negative margins and a sentinel lymph node biopsy. And at the time, her sentinel node was negative, but even if she were to have been found to have 1 or 2 positive sentinel nodes, we would not have proceeded with lymph node dissection, and she could have been treated with observation alone of the axilla per Z11, or perhaps she could have had axillary radiotherapy added as part of her whole breast radiotherapy, a la the Amorose trial. So with this new finding now post-operatively, again, I agree with Dr. Jockelson, we would certainly want better imaging to determine if this finding is suspicious or not. And then really whether or not if it were positive, again, it wouldn't be that surprising because we know in both the Z11 and Amorose trials that women who had 1 or 2 positive nodes, about 25 to 30% of them had additional disease in the axilla, but that disease was controlled, again, with radiotherapy largely. So I would be more concerned about negative breast cancer. We know that she has a high risk of distant disease recurrence in the absence of systemic her than further treatment to her axilla at this point in time.
Okay, thank you for that. Dr. Pegram, do you want to comment about her adjuvant chemotherapy options or what you would recommend in regard, given her comorbidities with rheumatoid arthritis requiring treatment with methotrexate?
Yeah, she's 74 years old. We don't know what her performance status is from the narrative or other comorbidities apart from rheumatoid arthritis, but assuming no other issues other than the RA for which she takes methotrexate, she is a candidate for systemic adjuvant chemo. I'm not sure for the reason of the delay in treatment previously, but in as much as she's chemo naive, now she has progression in the axilla, she should consider systemic adjuvant, quasi-adjuvant therapy. There's precedence for local regional recurrences benefiting from systemic adjuvant chemotherapy from the CALR trial. This case isn't quite like that since this patient's indeed chemo naive, but it's the same precedent. So I think she would stand to benefit. In terms of regimen, if she could tolerate probably a taxane with carboplatin, if she can't tolerate that, then even gemcitabine with carboplatin would be a consideration. It's very, very well tolerated, less toxicity than the taxane carbo combinations, in my opinion. There are other regimens too. If those were too much for her to tolerate at her age group, you could even consider old-fashioned tried and true regimens such as CMF. During her chemotherapy, I would drop the methotrexate for rheumatoid arthritis. She will have anti-inflammatory effects from systemic chemotherapy anyway. And so I would work closely with her rheumatologist to see whether she could get by with a cessation of methotrexate during her systemic therapy sequence.
Perfect. Thank you so much. You would favor an anthracycline-free adjuvant regimen, given her age and comorbidity. Perfect. Okay.
That's correct. For her age, I'm less enthusiastic to use anthracyclines in a case like this, especially now that we have the utility of platinum-based regimens established, particularly in the neoadjuvant setting where they have been shown to increase PCR rates by the addition of platinum. We're still waiting on the big pivotal phase 3 trials to look at time to event outcomes long-term with platinum-based chemo regimens, but it's likely they'll be active in the adjuvant setting as well, in my opinion.
Okay, perfect. Thank you so much. Dr. Shah, do you want to comment about the role of adjuvant radiation and then also sort of the impact of this delay, which, was because of, complications due to her rheumatoid arthritis. And so how does that impact the efficacy of the adjuvant radiation? And can you kind of share your thoughts with us about that?
Sure. So, in terms of looking at this patient, she really doesn't fall into the groups of patients we consider omitting radiation after a lumpectomy. We think about 65 to 70 and older, estrogen positive, her being estrogen negative and triple negative. I would almost always recommend radiation, barring significant comorbidities. Rheumatoid arthritis is often brought up as a contraindication or a concern for radiation. But to be forthright, there's growing data saying that they tolerate this quite well. There was actually a recent match paired analysis from Fox Chase Cancer Center looking at patients getting breast radiation with and without rheumatoid arthritis that showed almost no difference in side effect profiles. In terms of the methotrexate, it's usually very low dose methotrexate. So I'll usually talk to the rheumatologist, but it's not even the type of radiosensitizing doses of methotrexate. So they can often remain on their methotrexate during radiation. In terms of the delays of care, typically speaking, if you look at the literature, there's heterogeneity, but we like to start radiation in some series at 3 months and in other series at 6 months. So I would be concerned given the delay in terms of the efficacy. However, given this lymph node, what we might consider is starting with chemotherapy and then subsequently reevaluating her and considering after that kind of consolidative local therapy, whether that be surgery and radiation or radiation therapy alone.
Okay, perfect. Thank you so much.